Yeah, right. I know how that works.
No, I'm just, I'm being accepted.
Conversations about an office pet. Therapy.
Welcome. I just want to say hi. How are you? It's been a while.
Yeah.
I saw you and I said I gotta come say hi and all like that. Looking forward to talking. I have to leave at 11:45, so if I'm not hearing you finish, it doesn't mean I wasn't paying attention. Are you well? I'm good. Good. You look good. I'm excited. Yeah. Good. Thank you. It's good to see you.
Good morning. Please come in and take a seat so we may begin. Good morning. Welcome back to Institute Grand Rapids. If I could, as always, remind people please to fill out the evaluation forms. This is how we know that you're here. This gives us valuable feedback and program development. And of course, it allows Dr. Whiterout to monitor who's attending. So, without further ado, let me turn things over to Dr. Tricia Lester, who will introduce today's speaker.
Thanks, Ian. So it's my pleasure to introduce Dr. Bill Nash today. I've got notes because I want to make sure I include the things that I think are so important about Bill's contributions to the field. He currently serves as the Director of Psychological Health for the United States Marine Corps. Along with his academic and military colleagues over the last 12 years, he's advanced research in the area of assessment and treatment of combat stress injuries and moral injury, and through the study of risk and resilience in service members deployed to combat, helping us to understand opportunities for prevention, including what he's going to talk about today some, is the first large-scale longitudinal study of deploying service members to include archival records, biological, neuropsychological, psychiatric, and psychosocial assessments, as well as a linked NIH genomic study. Bill's also had a full career as a Navy psychiatrist while on active duty in the U.S. Navy. I think for 30 years he was in the U.S. Navy. Bill provided psychological health services to the 1st Marine Corps Marine Division in Iraq, and he led the development of the current Navy and Marine Corps doctrine for combat and operational stress control, which I know sounds like a lot of words to all of us who are familiar with military ease, but it's really a comprehensive framework for prevention and care that I think disrupted and reframed the way the military thinks about preventing combat stress injury and really promoting well-being in those serving in the military. He's won numerous military awards, including the Bronze Star during his service. He was a founding chair of the military committee for the Group for Advancement of Psychiatry and served as a member of the Institute of Medicine's Committee to evaluate effectiveness of PTSD treatment in the DoD and VA. He's published dozens of peer-reviewed papers and book chapters and co-authored 2 books on combat-related stress injuries and their treatment. I would say, on a personal note, I first met Bill in 2005. He was 2 months back from his deployment in Iraq. And I remember being at a meeting in some kind of a temporary building on Camp Pendleton Marine Corps Base. Was just immediately struck by the clarity of his vision, his sense of purpose, as well as his candor and humanity. And I really started a long-term partnership. It's been now, I counted it, 13 years that we've had the opportunity to work together, advancing, in our team's case, prevention for military families and veteran families. I would say his commitment to the Marines, their families, his deep clinical experience, and knowledge of military systems, and his dedication to research and advancing a scientifically supported approach to prevention has really led the field. And I think that you'll hear that today as he shares his work. And I would also just like to express my appreciation for his partnership. Finally, and I want to take up all his time, I want to say it's really a moment in time to have him here today talking about partnerships and the value of academic, VA, community, active duty, military, DoD relationships. All of these parties, big organizations, tend to become siloed. They don't historically work well together. But I think this war has changed things. Remember, 17 years in we are, with people still deploying overseas to the Middle East in combat in harm's way. And it's really, I think, a national priority for all of us to work together. And it's a moment in time when UCLA is deepening its commitment to veterans, both within the community and at the VA. The new partnership at the VA is we've opened a legal clinic, a veteran family wellness center, the new Center of Excellence for Homelessness and Addictions, because we can really think together and learn from Bill about his work with systems. So thank you for coming and welcome.
Thank you. Well, good morning, everybody. Thanks for coming. As I was putting this together, say hi to Catherine. As I was putting this together, I realized, whoa, this is such a minefield for me, because what I tried to do here ended up being almost like a summary of a large section of my career. And so it's a minefield of stories. And so I have to be real careful not to start telling any stories, because they're interesting stories, but I'll miss the point. So if I start telling a story, somebody throw a shoe at me or something, okay? And thank you for a great introduction. I didn't put any slides in here about focus, but I'm going to try to highlight the places where focus is, and the offspring of focus are really great examples of community mental health. Okay, so these are horribly written objectives, I think, but the gist of it is, number one, I just want to talk about community mental health versus clinical mental health. Clinical care versus community, medical, non-medical. Okay, that's a really important distinction. I haven't figured out the difference entirely, so I'm just going to show you how far I've gotten with that. Then I want to talk about, sort of an enduring theme is, you can't do community mental health. You cannot improve the health of a population unless you become part of that population. You have to be embedded. You have to make that part of your own identity, at least as a coat that you're comfortable wearing, to be a member of that community, right? At the same time, you bring in your professional expertise. So, and trust. That is absolutely fundamental to be able to bridge those divides. And I'm going to talk a little bit about some of the findings from the Marine Resiliency Study. This is definitely not a critical, I'm not going to give you enough information to critically appraise the study. That's all out there, you can get it. But I just want to highlight a couple of findings just so you can see it's, potentially worth the effort. So, clinical mental health versus community mental health. You can tell which slides I obsessed over the most. This is one because it took a long time to settle on these graphics. Around the outside are some of the contributors, but there are many, many more. The invasion of general systems theory into psychiatry, into medicine, in the 50s and 60s probably is most fundamental in, the biopsychosocial model obviously is part of that. So I'll let you read those distinctions. The one I want to mention specifically is the fourth one down, that community mental health
I think, needs to be delivered by community members. It needs to be wherever they live and work. It cannot be experts swooping in, doing magic, and swooping out, right? What's that old aphorism about feed someone a fish versus teaching them to fish, all that kind of thing. But the spectrum of challenges to health and resilience covers a lot more ground than anything we can possibly address with clinical practice guidelines in a clinical setting, right? So all these other subclinical things need to be understood and owned by the community members. I mean, everyone here knows something about first aid, right? You know, if you get a cut, you have some idea how to manage it acutely. You have some idea how to decide whether you need to go to an emergency room or not to get it stitched, right? Where's our psychological first aid? That's an idea that is one of the things we worked on. Haven't solved that yet. But that as a set of skills, community members need to understand. They need to know, okay, that's what this is. I've heard of this. This is not the end of the world. These are the things I can do. This is how I decide whether I need to get help or not. Those are decisions only the community members can make. By the way, if at any point something doesn't make sense to you, feel free to stop me, because I really would much rather be having a conversation with you. In fact, I'm going to back up to my first slide, and I'm going to ask someone to take a guess whether the picture on this slide was taken before the Second Battle of Fallujah or after the Second Battle of Fallujah.
Second Battle of Fallujah.
What?
Second Battle of Fallujah.
Yeah, so is it before the battle or after the battle?
After the battle.
Right, why after?
You can see that the Marines are more relaxed. After the first battle, many Marines came back very stressed out, very scared, with post-traumatic stress syndrome. After the Second Battle of Fallujah, most of my friends, myself, went through psychiatry help, and we were able to much more better understand what we were going through, talk about it, and express our feelings.
Thank you. Right. And all that is absolutely right on the money. But in terms of being part of a community, if you're there, as you obviously have been, you understand that you can't play like this before you're about to go into harm's way, right? But being able to play afterwards, that's pretty important. Okay, back to work. Okay, so a guy named Jack Pierce, who was a classmate of mine in medical school, University of Illinois in Chicago, graduated in '78, though I never met him there. He didn't go straight into the Navy like I did. He did work in community mental health in a civilian. I don't know what city, but he really embraced the community mental health model. So he came into the Navy and got stationed at the 2nd Marine Division in Camp Lejeune, which is the most of Marine Corps subcultures. Camp Lejeune is one where it's a little more conservative, put it that way, which means, some of the newfangled science stuff and, it just doesn't ring as true to them as it does elsewhere. But he went there and he developed this Oscar program as a team approach to handling all psychological health problems for Marines in that community. And the way he did that is he convinced, actually General Neller, who's currently the Commandant of the Marine Corps, the top 4-star, was his regimental commander back in Lejeune in '99. So that's how he got sold on this. And he convinced Colonel Neller to give him 2 high-quality staff NCOs, gunnery sergeants, who were not people who couldn't work anywhere else, and they were highly respected. They were the people that were in demand in other critical jobs. But being respected is critical because, in order to be effective, you need that trust. So he created these teams, and they, together as a team, evaluated and responded to and took care of everything that walked through the door. So imagine that. So every Marine who came in and said, I'm thinking about killing myself, or I'm depressed, or whatever. So you got community members and mental health professionals together, psych techs, chaplains, psychiatrists, psychologists, social workers, and Marines, figuring out together what's going on here. And so you get the line Marine perspective. Oh, he's just trying to get out of something, he's a malingerer, which could be true, right? But then you sort of together, you figure it out. So then you can go back to the command, which is also critical, because they're part of this. They have the ultimate responsibility. People don't understand that in the healthcare world. You know, commanding officer is like a parent of a family. Not like, they are. And if one of theirs dies, who shouldn't have died, that's a wound they're going to carry the rest of their lives. So it worked. We don't have data to prove that. There have been a couple studies of this part of the Oscar program, and they haven't been able to demonstrate effectiveness. Biggest problem is inconsistency. The Marine Corps did a terrible job implementing it. Didn't even write down the doctrine. There was no training. Obviously, that's not going to work. So we could have learned a lot from Tricia had we been able to partner with her in building that. But I was already gone by the time it was fully implemented. But I did volunteer to be one of the first Oscar psychiatrists to deploy with the 1st Marine Division in 2004. I want you to think about what that would be like. Imagine you've spent your whole career doing clinical care and treating the aftermath of combat in all its many faces. And now all of a sudden they say, we want you to go with the Marines into combat. You're not going to work in an MTF. You're not going to work in a clinic. You may see patients, you may not. But if you do, it's going to be wherever you can, sitting on a rock, sitting in the dirt, right? But what's your job? Your job is to bring them home. Your job is to keep them well, right? How do you do that when all you know is clinical care after the fact? It's a totally different animal. So fortunately, I had about 8 months to prepare for this, and I read frantically. I talked to people, and most importantly, I spent as much time as I could out in the field with the Marines, shooting shit and breaking stuff and learning who are they, you know, who and how do they see the world. The biggest challenge then to be a psychiatrist or mental health professional deployed, embedded in a combat unit is preventing PTSD, right? That's the big ugly monster. So how do you do that? Well, 2004, when I took this on, from what I could tell, we were still very much seeing bad mental health outcomes from war zone stress as the result of pre-existing vulnerability, the stress diathesis model, right? And the question that every general, every colonel, every gunnery sergeant asks is, okay then, explain to me why I went through the same thing and I don't have PTSD, right? That's the question. And their answer to that is, well, it must be because those who do brought some vulnerability that was just unmasked by the event. And that's the thinking that still exists in many areas, many circles, and many people. Although, thank God, it's changing. And that came actually from World War I. So here's just, I'll throw this out. This is one of my answers to those Marine leaders who ask that question. I say, look, I could build a scaffold in this room, and I could build it just high enough that if we invited you all to walk up the scaffold and jump off. Whatever percent we want, we'll have a broken bone when they hit the bottom. We'll break a bone falling, okay? Pick a number, 8%, 10%, 15%. Well, it's, roughly the prevalence of PTSD post-combat exposure. So it has to be that there's a certain height where roughly, statistically, that number will break a bone. If it's high enough, they'll all die. If it's low enough, no one will break a bone, right? Right? You with me? Does that make sense? Could you, for a minute, would you consider asking the question, why those 8 people out of 100 broke a bone when the other 92 didn't? Would you say, you must have brought some pre-existing vulnerability to that situation. Otherwise, you wouldn't have broke a bone. I didn't break a bone. And could you imagine that if you could do the experiment again with the same 100 people, would it be the same 8 who had a fracture? That's ridiculous. The world doesn't work that way. It's all about how you hit. It's all about the impact, right? So, PIES in 2004 was still the doctrine throughout DoD, throughout the world, in military settings. Was created in 1917 as a way to staunch the flow of money from all of the countries fighting World War I, because shell shock and nerve shock was so expensive. And it's based on expectancy. So the E of PIES is reassurance. There's nothing wrong with you. It doesn't matter. You could have a full-blown manic episode. You could be psychotic. You name it. You could be so regressed that you're in a fetal position, but you're going to be fine in 48 to 72 hours. But if you're not, we're going to say it was because there was something wrong with you before, and you have a mental disorder. Yet we knew from Hoag's work and others that PTSD does happen to a significant percentage of those exposed. So this mantra, normal reaction to an abnormal event, that has made me crazy my whole career, because, come on, if it's all normal, what is there to prevent? Right? How can you go from this is all normal over here, yet a certain percentage are going to be screwed up for life, right? Over here. Somewhere there has to be a boundary, right? You have to cross a boundary. So I wasn't the only one who thought of this. One of the chapters in this book was written by some Canadians who came up with the term operational stress injuries. First time I heard the Canadian version of this was I shared a podium with General Dallaire, Romeo Dallaire, who was until recently a Canadian senator, but he was the commander of the UN peacekeeping force sent to Rwanda during the genocide. So his job was to prevent genocide. So you can imagine. And he had the foolhardiness to volunteer to stay there with a very small group of UN peacekeepers just to watch this thing unfold. So, he just wrote a book, published last year, I think, called Waiting for Dawn, Waiting for First Light. It's about his personal moral injury from that experience. So I remember hearing him speak and talking about these as stress injuries, and I was just beginning to try to promote this idea that this is an intermediate state. It's not normal. It doesn't just go away, right? You cross the line, and some part of you is not functioning the same way anymore. So he called them stress injuries, and I asked him, I said, why do you say that? And he says, if it's happened to you, you just know it, right? If it hasn't happened to you, you can't imagine it. So somehow we got from me going out, and I did not pull punches. I thought about showing you some of the slides I created back then, 2005, 4, 6, 7, leading up to the creation of this doctrine. And I had pictures of bent trees and broken trees, and I had pictures of football players with broken legs, and showing these to Marines and Marine families. And a certain percentage of them said, you got something there. And then another certain percentage were furious. How could you? They were, upset about this. They certainly didn't want Marines to get this idea. And so 3 commanding generals of 3 Marine Expeditionary Forces, which is basically all the war fighters of the Marine Corps, Lejeune, Pendleton, and Okinawa and Hawaii. And they got together, and it's the only time anyone can remember where the 3 MEF commanders, 3 MEF commanding generals, who are highly competitive siblings, right? They don't collaborate on anything. They signed a joint letter to the Commandant of the Marine Corps in 2007 saying, kill Nash and kill the stress injury idea. We don't want to ever hear it again. And I was at headquarters Marine Corps then. I'd already obviously back from the war. And I was at Quantico, and the people there I work for said, well, here's your plane ticket. Good luck. Go out to California and meet with these champions of the 3 MEF CGs. By the way, the 1st Marine Division, or actually the 1 MEF commander at the time was Jim Mattis, who I'd served with in Iraq. So I think they auctioned off my furniture while I was away because they knew I wasn't coming back. But somehow, this group of people, which was mostly community members, a few healthcare professionals, a few chaplains, and of course I was channeling in there as the champion for this idea. I was channeling people like Tricia and other collaborators I'd had on the scientific side of this to have the courage to fight for these ideas. And somehow they got to this. So the green, yellow, orange, red is the stress continuum. So they said, you know what, we think you got something here. We think stress injuries are real, but we want to put them in this context of, it's a spectrum. From that, they created the 5 core leader functions. These were Marines. And the 5 are strengthen, mitigate, identify, treat, and reintegrate. And they map almost exactly to the Institute of Medicine protractor interventions, which was just amazing. And we added some stress first aid. I'm not sure there's anything of value there yet. It needs a lot of work. So how did we get from this idea of stress injury to the doctrine, which is Marines now training Marines in the importance of understanding these concepts and tools, how to recognize, how to treat, how to mitigate? How did we get from one place to the other? Well, from my perspective of having lived through it, and I'm sure you can imagine if you put yourself in this position, it was only because members of the community became leaders of this conversation. They put themselves on the line. They decided this is important for my welfare, for the welfare of the people I care about. So that's, to me, that's everything. How do you get from an idea to action in a community? I was asked to chair this working group in 2009 to develop recommendations for common data elements for operational stress research, federal consensus, and we were able to sneak through moral injury and loss and grief and things that are not popular in the war-related PTSD world, but seemed very fundamental to where we were headed with this. And we developed these aims for operational stress research. And I had forgotten about them until I made this slide and said, you know what? This is pretty good. We want to identify at-risk populations. We want to figure out how to recognize a stress injury early so we can give indicated prevention, right? Like Focus does with families. Metrics, trajectories, and modifiable risk factors. Okay, Marine Resiliency Study. This was a collaboration, actually started very soon after I got back from Iraq. I was asked to give a presentation on this stress injury idea at Naval Health Research Center in San Diego. And one of the people in attendance was Dulene Baker, who's a psychiatrist at UCSD, actually works at VA San Diego. And she said, you know, I think this is a great idea. I've been thinking the same thing. We should do it. And the fact that this happened is all about her. I mean, I acquired and kept the trust of the Marine Corps and the Navy to make this happen, and I helped get the first couple million of funding. But in terms of actually doing this monster and making it happen and carrying it through, that's her and her team. We had four cohorts enrolled over several years, and of course we couldn't get that done until I had briefed 3 consecutive commanding generals of the 1st Marine Division and the regimental commanders, and did a focus group with Marines. And I mean, this was something they were either going to invest in or they weren't. So these are some of the many champions who helped push this through. I know you're not going to recognize any of those names, but they'll recognize them. And these are 4 data collection time points. I did not include in here slides with all the measures we used, but it was truly, we drew blood, we collected RNA and DNA, panel of biomarkers. We used CAPS interviews as our main outcome measure, which, is not an easy thing to do. Although in the T1 time point, which was 1 week post-deployment, we didn't want to make them sit through anything that tedious, so we just used the PCL for that one time point, which just kind of makes some of the analyses difficult. That's just so you see the breadth of it. And these are our 4 cohorts. We were astounded. If you look at the rightmost column of the first table, the percent that completed the final time point, the first cohort, 85%. We thought, because I knew the reason for that was some of our technicians were in the habit of partying with the Marines after the data collections. So I think that helped. But still, it's not bad. But the lower table, this is sort of a bizarre challenge that we faced that we didn't anticipate. The first 2 cohorts went to Iraq in 08 and 09 when things were pretty quiet. It was way after the worst of the fighting. So the rightmost column is sort of the mean combat exposure score for those cohorts. I can tell you that's not high enough to have very many combat-related PTSD cases, which means our ability to really discern any signal is pretty weak. So we were pretty much left with the last 2 who went to Afghanistan during the worst of the fighting there. And our cohort 4, it was notorious almost for the magnitude of what they faced. And so it was cohort 4 that ended up giving us most of our findings. Okay, so I'm just going to go through a couple of the findings with you, and I'm excited. We're going to have lots of time for conversation. So this is, and I'm not going to address any of the biological findings. Dulene and her team, UCSD, are still messing with that. These findings are all from Brett Litz and my partnership with him and at Boston for the psychosocial more findings. So this is one thing we did. Now remember, this was one of my goals for this study is to test the stress injury idea, to test the stress continuum, to get some data to show that this idea is anchored in reality, right? So one of the things we wanted to do is there an orange zone? Okay, we've got CAPS as our main outcome, so we're only looking in this at post-traumatic stress as one of many outcome domains. And really, if you're not oversimplifying, if you are thinking in terms of green, yellow, orange, red, that spectrum can apply to every domain in your life, your social functioning, spiritual functioning, physical and dental, So this is just PTSD, but we wanted to, so is there an intermediate state? So we did using CAPS and using, this is DSM-4 TR, 4-5, but looking at the PTSD symptom clusters, looking at, how, and using latent class analysis. So what are the latent classes? This is what we came up with. The topmost graph were the people who met full criteria for PTSD. Red zone, 9.5%. We found two different latent classes of subclinical PTS. One, the less common one, it was 7.9%. If you can follow that pale blue line, you see that it has a very high spike in the numbing cluster. So this is a group of people who don't have enough re-experiencing to meet criteria for PTSD, but they're even more numb maybe than the people with full-blown PTSD. What does that mean to them socially, occupationally, right? Studies done in the aftermath of Vietnam showed that, surveys done with spouses of veterans said the numbing was the thing most destructive to family relationships. So that was one orange zone latent class. And the other one, the more common one, had significant but subthreshold re-experiencing and avoidance, but not the numbing, but had the arousal symptoms. So we call that anxious and arousal, and we call the other one numb and arousal. So together, in the pie chart, they added up to 34% at 8 months post-deployment, right? So if you are responsible for the health of a population, and I show you this pie chart, and I don't know, we don't know what it looks like 2 years later or 10 years later, who knows? And I show you this pie chart, where are you going to put your money? Our clinical healthcare systems pretty much say, well, we're only supposed to treat the red zone. If you don't meet criteria, our clinical practice guidelines don't apply necessarily, right? There's a lot of fudging that goes on. But in terms of risk, life risk, I think there's growing evidence that it's the acute subclinical stuff that really leads to suicide and violence, because people are not adapted to it yet. And sometimes, it's limited symptoms, but they can be overwhelming. Okay, this is trajectory study. This is the thing this was our big main goal, is we wanted to use growth mixture modeling to try to let the data, so growth mixture modeling, you don't apply some theory. You don't say, well, I'm going to test this hypothesis. You let the data find these patterns. And so the best fit to the data was these three trajectories, pre-existing 8%, new onset 13%, and low stable symptoms 79%. So in terms of the goals of recognizing modifiable risk factors, we tested, we had like 900 and some variables. So we looked at, that list is just a very small subset. We looked at cohesion and family support and you name it, across the spectrum. Childhood trauma, using childhood trauma questionnaire, accounted for 1% of the difference, 1% of the outcome. I know some people are, for good reason, wanting the world to know there are consequences, lifelong consequences to childhood abuse and neglect. All I can say is, among highly trained, highly culled out, elite combat forces, it just didn't end up being a predictor. The top predictor was peritraumatic dissociation. In fact, one of the other projects that we did as part of the Marine Resiliency study is we created a new instrument, a new measure for peritraumatic dissociation that we call the Peritraumatic Behavior Questionnaire. The one we used for this was Charlie Marmer's PDEQ, Peritraumatic Dissociation Experiences Questionnaire, which is just cognitive dissociation. But there's people who've worked in the area of somatoform dissociation since World War I, and there's plenty of observational experience that one of the consequences, one of the acute peri-event consequences of trauma can be a lot of physical changes, numbness and paralysis and stuttering and, really weird things. People can, lose allergies they used to have, or, different speech patterns, and a lot of bizarre stuff that no one understands. But I don't want to go into a lot of detail, but what we found is when you add the somatic forms of dissociation to the measure, it actually is the best predictor. What happened to you at the time of the event, your score in this is better predicts chronic PTSD than anything else we could find. Certainly way better than the severity of the combat experiences. So it's about how you hit. It's about how you hit. It's about the impact, which is great because we can do something about that. We can learn to recognize that in a compassionate way and help people recover from it, which is the modal course, is to recovery, right? Can't prove it yet, we know that's true. The second best predictor was avoidant coping, and our team couldn't come to one mind about this. There was, mostly cognitive psychologists, and I'm not in a position to critique their science, but they were looking for these pre-existing weaknesses. And so there was a part of our team that wanted to show that people who had avoidant coping styles before the event were more likely to have chronic PTSD, and that's part of the prevailing model of PTSD. What we ended up doing was averaging avoidance over the 4 time spans, which really isn't that helpful because avoidance is a symptom of PTSD, right? So is that chicken or egg? I don't know. So I don't know what to make of that finding, but the dissociation is... So any thoughts, comments, questions about any of that? Okay, another thing I want to mention is one of the fruits of this effort was recognizing that stress injuries can be caused by a lot more things than just threats to your life. Loss, grief, complicated bereavement, obviously. There's plenty of evidence to show that grief, events that cause shame or extreme anger, and life threats and wear and tear can cause the same spectrum of symptoms, very similar, if not the same changes in the brain, allostatic changes. So one of the things that came from this was realizing that the model we had been working with up until about 2007, based on a review, not of the scientific literature, but the history of books and journals and things written by the people who lived through wars, saying, this is what haunted me the rest of my life. This is what caused me to suffer in my family. And realizing that fear and danger is one group of things, loss is another huge group of things, but there was this other group that we didn't have a good name for that ended up being moral injury. So this was a moral injury event scale we created for the Marine Resiliency Study. It's a crappy scale. We did not do a good job with this. We wanted it to be a measure just of events, of exposures. So it's kind of like a combat experiences scale or life events checklist, people who do that kind of research. It's just events. But we ended up putting in things like, I saw things that were morally wrong. Well, you have to make a judgment to say that it's morally wrong. So we ended up blurring those appraisal things with just perceptions. So nevertheless, and we had 3 subscales: perpetration by someone else, perpetration by the self, or feeling betrayed by someone that you trusted. Brian and his group, Utah, have since validated it in 2 other military and veteran populations, including demonstrating a connection to suicidality. So this is just to show part of our validation process for the MISE was we looked at these 5 different event types. There's 5 different stressor types is what they are. Combat events, which is DRRI combat exposure scale. It's, how many times did you get shot at? How many times did you return fire? How many times did you kill someone? How many times did you get blown up? Dead bodies, that. Aftermath of battle, that's more dead bodies. That's cleaning up the mess. It's the smells and the sights and sounds. Perceived threat is, I really thought I was going to die. Life and family concerns, you know what that is. And moral injury events. So what we did is, and each of these is plotted on a standardized scale, so it's their percentage of maximum scores, so you can compare them. And what we did is we took these 208 Marines, highly exposed, combat exposed Marines, and based on their CAP scores at 8 months post, we put them in these 3 categories. Full-blown PTSD, red zone, subclinical, orange, and not even subclinical, yellow. The only one of those 5 exposure types that significantly discriminated yellow from orange, orange from red, was moral injury events. Not combat events, not aftermath of battle, not those other things. This is one of our more recent papers where we looked at pathways from 3 different trauma types. The middle one is a fear-based event. The top is perpetration moral injury. The bottom is betrayal moral injury. And what we found is if you put guilt and shame, anger and dissociation in as mediators, the direct pathways disappear as insignificant. So in our data, with our population, the pathway from perpetration of a morally injurious event to PTSD was through guilt and shame. The pathway from betrayal, feeling betrayed, to PTSD was through anger, and from combat was through dissociation. Once again, to me, this is great news because these are things we can monitor. We can measure these things. We don't have to ask them, were you abused as a kid? By the way, had these conversations about childhood trauma with many leaders in the Marine Corps. And one of the cool conversations that's happening now about that is every time I bring it up in a meeting, these high-ranking Marines start telling their own stories of horrible childhoods. They all have horrible childhoods. But these are things we can recognize and do something about. Okay, so this is my last slide, and we have 10 minutes for conversation. So Tricia sent me this paper about the adaptome, which is really, I think, very cool. And it speaks to the challenge of community mental health, population health. The only things that have a chance of working are interventions, approaches, conceptions that fit both, right? Evidence-based and culturally valid. Scientific validity, cultural validity. You can imagine, maybe you can't, but I'll tell you that over 100 years, more than that, forever, the approaches the military has used to protect the psychological health of their members have been all things that had great cultural validity, but no science behind them. There was one example. There's a former Marine, former Air Force enlisted, working at Uniformed Services University in their Human Performance Optimization branch. And his big success story was he created a training program for airmen headed into combat called One Shot, One Kill. This was a psychological health promotion program called One Shot, One Kill. Now you can imagine it was popular because there was no foo-foo in there, right? But there also wasn't much psychological health in there either, right? So that's the problem. And if, we start more in, okay, this is clinical practice guidelines, but if you're going to make something work within a culture, you can't just use what's already proven effective, because if there was something already proven effective in your community, you would know about it, right? So you have to, so to me, it's all about growing the sweet spot, and you do that by teaching and learning, okay, so what are your challenges? What is it you all face day to day? What causes you the most pain and distress and destruction, right? And what are your resources, and what are you willing to do? And then teaching them, if you could incorporate this other idea into your worldview, you might have a better shot. Something like stress injuries. So any comments, questions? Thank you.
Okay, we have time for questions?
Yes, my name is Angel. I wanted to ask if you could provide details regarding the inclusion criteria for your resiliency study. Specifically, I'm asking if there was anything confounding regarding MOSs, specifically like 0311s compared to the rest of the MOSs.
Yeah, so the way we did that was, there's a lot of different ways to try to get a statistically representative sample of people. And we did it by trying to enroll as much of a total cohort as we could. So we enrolled them by battalions. And the inclusion criteria was, you're a member of that battalion. It's voluntary, so you come if you want, and that was it. So I didn't bring the slides. We did comparisons between the MOSs and ages and marital status and all those things from our table 1 to Marine Corps as a whole. But that's how we did it.
Dr. Dunn?
Hi, Bill. Fantastic talk. I wanted to ask about how applicable you think these findings are to service members in the other services and also, non-combat service members. So as you know, Marines are a very special breed of service member. Combat Marines are even more a special breed. And dare I say, and I don't want to overgeneralize, but a lot of them, when they go out, the mentality is they're expecting enemy contact. They're looking for a fight, right? They're looking for the enemy. And the reason I ask this is because at the VA, and when I'm thinking about my own patients that I see in the PTSD clinic, I'm actually struck that actually a lot of them are not in primary combat MOSs, right? They were truck drivers, they were comm people, they were people not expecting their MOS to be outside the wire, but given the type of combat and the situation that existed in these conflicts, they were often put in those situations. So would these findings bear out into again, other services and those service members who are not in primary combat MOSs, but experience some type of trauma?
Absolutely not. You're right. There are real barriers to generalizing these findings in this population to any. So an example of a group that would have very different experiences and outcomes would be reservists or guard, right? People in non-combat roles, obviously these are, in the Marine Corps, the cream of the crop. They get the best preparation, the longest training, all that stuff. So yeah, you're right. It doesn't necessarily generalize. We focused on this population to do this study in because we wanted to show the Marine Corps that even in their best, this is, it's not something that just strength of will could overcome. But you're right, it doesn't necessarily generalize. Any other?
Hi. I was really struck by the fourth cohort in the study that was more kind of heavily hit.
Yes.
But they also brought down your dropout percentage.
They did.
So I guess what are your thoughts on that? And then how do we go about trying to capture those people's experience?
Yeah. Well, it certainly does weaken the study. Some of those Marines who did not complete were killed in action. So there was a significant number of those, but that doesn't explain the rest of it. Yeah, so that's a confounder. We don't have any way to show that those who do complete it were somehow representative. That's a challenge.
Do you think their PTSD got in the way?
Pardon?
Did their PTSD get in the way?
It could have. It could have.
Being able to.
Yeah, right. Yeah, I can well imagine if I were one of them and I had been through the CAPS twice already, and now all of a sudden I can't say no anymore. I wouldn't want to go. So you could well be right.
So I have one last question that may be longer than you have time to answer. But when you think, so I'm thinking about all the lessons that the military being engaged in this long war had brought to medicine in terms of trauma care, surgical care, and psychiatric care. And when you think of something like implementation and learning from practice-based evidence, integrating it with evidence-based practice, and how this has been done
I like that.
inside of learning health systems, I think you all have, for the military, you're there now, has large data systems that they've been able to potentially harness. I know there have been some efforts at that to really learn from practice.
Yes.
Start to inform how things are adapted, how they do fit culturally. And I guess I'm wondering if you think there have been any successful examples of that.
Oh, we are in the Marine Corps. We're just beginning to do some big data analytics, predictive analytics. They scare the hell out of me. I'll tell you, that's an area where we need to do some serious thinking about ethics. Who owns this information, et cetera, et cetera. But it's powerful, and powerful things can do harm. But one example of a success for the Marine Corps, not so much for psychological health, but one of the things they were looking at is early attrition. Okay, looking at Marines who leave the Marine Corps before the end of their obligated service, and the reasons for that, and is there anything that we can do to? And so one of the things they found was significant number of those non-EAS attriters had pre-existing health problems that the recruiters may have said, well, just don't mention that, and I won't, and that kind of thing. And so they did an analysis to see whether those kinds of enlisted in error happen more commonly with certain recruiters rather than others. And so the first finding was there are certain recruiters that had more of those than their share. So right away, the Marine Corps is thinking, oh, we're going to kick some ass, right? So I said, wait a minute. What about the recruiting stations? Sort them by recruiting station to see how much the system, the culture, is promoting these things as opposed to the individuals. And what they found was actually certain recruiting stations, and recruiters who went to those recruiting stations became tainted afterwards. And so that's a whole new area.
Can I ask one last?
Yes.
Could you go to your path analysis slide, please?
Yes.
Because as you so eloquently said, it's about the impact.
Right.
So what are your thoughts about what can be done to modify some of these factors so that we can change the impact? So that, yeah, they jump off the platform and fall, but they don't break their leg. What can be done?
Oh, great question.
In 30 seconds.
Okay. It's easy. Okay, so the first thing is, I believe moral injury is an information injury. We are information beings. And so one way to prevent at least the guilt, shame, and anger from the morally injurious events is preparing people for the truth, right? So, we don't know how much naivete or certain kinds of, immature kinds of worldviews or self-conceptions may contribute. But the better they know what's really going to happen, less chance. So that's number one. So that's universal prevention. Indicated prevention or selective prevention, okay, so what are we going to do with the people who come back feeling ashamed or guilty or angry and not just sweep it under the rug? So universal and selective and indicated.
Great. All right.
Thank you so much.
Thank you, Bill.
Thank you.